From the Baker Institute for Public Policy at Rice University in Houston, Texas, this is the Baker Briefing. I'm Joe Barnes, Research Fellow at the Institute. Today's topic, the high costs of U.S. healthcare. In 2021, U.S. healthcare spending reached $4.3 trillion. That's roughly $13,000 per person. The United States spends nearly twice the amount on healthcare than any other developed country, and yet it is the only developed country that does not guarantee its citizens health coverage. This snapshot is even worse in Texas. According to a recent estimate from the Census Bureau, the state of Texas has one of the highest share of uninsured Americans at 16.6%. Today, we're going to talk about the factors that have increased health care prices and how policymakers can address the high cost of health care. With me today is my colleague, Elena M. Marks, a senior fellow in health policy at the Baker Institute. Elena, thank you for being here.
Thanks for having me.
Elena, let's start out with some basics. Healthcare affordability is not a new or an emerging topic. It's been a hot-button issue in U.S. politics for decades. But despite this scrutiny and this political attention, the cost of basic health care in the United States have continued to rise. So let's start with the fundamentals. Elena, can you put the extent of the healthcare affordability issue in context? Today, in November 2023, just how unaffordable is healthcare in the United States?
Let me put it in the context of a comparison to GDP, gross domestic product. In this country in 2021, and that's the data that you quoted us where it's almost $13,000 per person. In 1970, that figure was $353 a person. And if you adjusted it for inflation, it would have been $1,900. So what we spent $2,000 on in 1970, we're spending $13,000 on in 2021. Also, the percentage of GDP that health expenditures comprise went from about 7% in 1970 to over 18% today. And so health and health care are taking a bigger chunk of the economy than they previously did.
Right. And this leads to another obvious and very important question. Are we getting value for this immense amount of money we're spending?
That, to me, is the problem. It's that we're not getting value. I think if we believe as a country that health is really important and that it's worth spending almost 20% of GDP on health, I can buy into that. However, if that's our goal, we are falling far short because our health outcomes and some of the most basic statistics like life expectancy, infant mortality, maternal mortality, obesity rates, our rates are worse than all of the other developed countries, despite the fact that we continue to spend more and more and more on health. And I would say the reason for that is that we are spending it on primarily medical care, and medical care is only a small contributor to overall health outcomes.
Now, that's a very, very interesting and important point, because there really is a difference between health and healthcare, right?
Absolutely. One of the things that has happened in this country is that we have literally conflated the two terms. People use the words health and healthcare interchangeably. And when they talk about health, they often say healthcare. And that's because that is what we have prioritized financially in terms of our investments, but also culturally. We have a country that thinks that going to the doctor, getting a pill, getting a procedure, having a scan is what makes you healthy. And because we are culturally biased that way, and because we love technology, and there's more and more technology that is advancing medical care, we really conflate the two. And so when we talk about whether or not people are healthy or whether or not we are spending enough on health, they automatically go to health care.
Now look, back to healthcare costs for a minute, because they are important. They're not nearly the whole story, but they are important.
They're important because we're paying too much and getting too little.
What does it mean for, let's say, a poor family in terms of the sort of health they can achieve given current healthcare costs? Does it affect them, or does it depend on whether or not they're on a government program?
It affects them, but even more importantly for lower income families, are all of the non-medical factors that are more determinative of their health outcomes than health care. Now, in the U.S., we have a sick care system. We do not have a health care system. And when we have lower income populations who don't live in safe neighborhoods where you can walk the streets to exercise, who don't have access to healthy, affordable foods, who may live in polluted areas or may live in areas where the housing stock is so poor they're exposed to asthma triggers in their own homes and apartments, they are set up to be unhealthy. And they get a double whammy because they don't necessarily have health insurance. And in the U.S., we have built our system of access to health care, and I mean health care, based on the notion that you have some kind of insurance coverage. And because we have done that, we have made it so that without health insurance, the ability to get basic health care can be very expensive.
So we know that costs have been rising rapidly. We know that rising costs, in addition to a number of other factors, are an impediment to full wellness. But why? Why have prices gone up the way they have? Is there one cause? Are there two causes? Are there three?
At least three.
It's never, when you talk to an expert, it's never just one answer. Anyway, go on.
I'll name a few, and we can talk about any or all of them. So first of all, in the U.S., we have an aging population. Older people cost more. Period. End of story. If we actually wanted to reduce healthcare costs, we would all drop dead right now. Truly, because the longer you live, the more healthcare costs, medical costs you will incur. And so to the extent it's because people are living longer, that's not a bad thing. But it is a factor that has driven up the total amount we spend on healthcare. There are just more people who are older and they use more healthcare. We also have had a lot of advances in technology that often aren't any better in terms of patient outcomes than their predecessors, but they cost more, and we are crazy for the latest, newest thing, and so we seek them out. Healthcare, unlike many other sectors, has a supply driving demand problem that you don't really see elsewhere. We hear about these things that they can do for you in a great medical center, and suddenly we think we need them and that we want them. The costs relating to inflation in general obviously affect the healthcare sector as well. COVID did a number on everybody, but particularly on people who work in the healthcare sector. People got sick, they got burned out. There's been a lot of people leaving the field because of what happened during COVID and just how tired people got. We have a very significant for-profit element in our healthcare system, and the place people see that the most or talk about it the most has to do with pharmaceuticals, where even though a lot of the basic science is funded by the federal government, there are a lot of pharmaceutical and devices that are developed having used public dollars for basic research, but then the intellectual property ownership rights reside in a for-profit entity, and for-profit entities, they're not evil, but their role in society is to make money. And so when you've got a for-profit entity in the mix, you have to recognize that that part of what they are trying to do is make money. So those are some reasons.
And I'm sure there's more. Now, look, let's move away from the United States for a bit and let's get closer to home here in Texas. The Texas Medical Association has called our state the uninsured capital of the United States. Why is this?
Well, they're right. They could lobby harder to change that, but while they're in favor of changing that, they don't prioritize that. The main reason for that is because Texas has not expanded Medicaid. When the Affordable Care Act passed in 2010, it had a plan for almost all Americans, regardless of income, to be eligible for affordable health insurance. Again, because health insurance is our entree to health care. And for the lowest income people, what the Affordable Care Act did was provide Medicaid coverage. It's a state-federal combination of public health insurance that provides very comprehensive care. For the sort of high, low to middle income to upper middle income people, the ACA created a health insurance marketplace where people could buy competitive plans that had good coverage at varying prices, and depending on their income level, they could get subsidies that would make the plans more affordable for them. And then for people who are at a higher income level, there have always been individual plans that people could buy. And remember, in this country, almost half of us get our health insurance through our employers. In Texas, it's a little bit below 50%. But the ACA put in place these arrangements that would essentially make health insurance affordable regardless of your income level, assuming you were a legal resident. And part of that became optional. And the optional part was what everyone refers to as Medicaid Expansion. And the Supreme Court decided that the Affordable Care Act was a legitimate law. It couldn't be struck down except for the provision that said that the Medicaid expansion was mandatory. And so they said each state had to make its own decision whether or not to expand Medicaid. 40 states have made that decision to expand Medicaid. Texas is one of now down to 10 states that have not done so. And when you don't expand Medicaid, you have a population of people who make too little money to qualify for these subsidies and are not getting employer-sponsored insurance, and make too much money to be on traditional Medicaid, where you have to be essentially very, very, very poor and or disabled or pregnant. And so we've got a population of about 1 million Texans who would have been eligible under the ACA had Texas expanded Medicaid. When Texas didn't, it basically left them out in the cold.
And this involves federal money, so the state of Texas is leaving money on the table here, right, by not expanding Medicaid?
Yes, there have been numerous analyses over many years about the cost to states of taking on the Medicaid expansion. Now, states do, originally the federal government paid 100% of the expansion costs. Over time, that has gone down to 10%. But even at 10%, there are multiple economic analyses for Texas and for other states that show a net gain to the state treasury and to the overall economy when Medicaid is expanded, not to mention health gains.
Do the critics of Medicaid expansion have any merit to their arguments at all?
I believe the critics currently have ideological differences that keep them opposed to Medicaid.
I appreciate your diplomacy. We've talked a little bit about the affordability crisis and discussed how we got here, and dug a bit deeper into the situation in which we find ourselves here in Texas. Let's go to the hard part, which is how do we go about fixing this problem? Not just the healthcare problem, but also, as you point out, the health problem.
I'm so glad you asked that question, because I know we can fix it. We built the system we have today, and we can change it. It's not God-given. We made it. And it's actually starting to change, and here's how that's happening. The reason that we are spending the money primarily on hospitals, secondarily on other medical services, is because that's what the payers are paying for. And the payers are primarily the federal government, who pays for Medicare, what covers older people. They pay 100% of those costs. Medicaid, which they and the state share. And then you have employers who are responsible for a lot of other costs. What we are seeing is, as they have finally said, enough, we just can't pay anymore, they've started to look not just at how you reduce the costs, but how you also redeploy those dollars so that they are more effective. So, for example, there's been a lot of movement over the last 10 to 20 years to provide services outside of hospitals. And so you see ambulatory surgery centers popping up, and you see all sorts of independent diagnostic centers. And so people are moving, and the federal government is prioritizing paying for services outside of hospitals. that reduces costs. It also improves the outcomes because it's really hard to keep people safe and well in even the very best hospitals. It's gone much farther than that, though, where we are now seeing the federal government and some states, including Texas, recognizing that all of these non-medical issues are adversely impacting Texans and Americans. And if we can use some of this $4.3 trillion to address those problems, then we'll get farther. The best example I can think of is in the case of food. You understand, of course, that food is tied to health, very intrinsically tied, whether you're talking about obesity or diabetes or hypertension or just plain old survival by having enough food to eat. And we are increasingly seeing Medicare programs and Medicaid programs allow, and in some cases incent, the providers or the health plans that deliver these programs to give their members access to food. It could be a medically tailored meal for a diabetic, for example. And so as we see dollars moving out of the most acute sick care setting and into a more prevention and wellness oriented setting, I think we will see we may see healthcare costs go down. We will see health outcomes rise.
A couple last questions. You're going to be hosting a conference here at the Baker Institute next month. What's the subject?
It's exactly this, the non-medical drivers of health. There's so much movement underway, including in Texas, where we had a wonderful bill that passed in the last session that relates only to pregnant women who are on Medicaid, but it recognizes that so many of their adverse outcomes for the women and the babies are tied to non-medical factors. And so we are capitalizing on the investment by the state of Texas in making sure that women who are pregnant and in need have access to food, have access to housing, have access to solutions for intimate partner violence, have access to transportation, because we understand how critical that is for them to have a healthy pregnancy and deliver a full-term healthy baby. And this conference is bringing people together from across the state who are working in the healthcare system and who are interested in and doing this kind of work.
Well, look, I'd like to thank you, Elena, for a wonderful discussion of issues that are of grave importance to everybody. You're particularly good at explaining somewhat complicated materials in a way that even idiots like me can understand.
Thank you.
Today's episode was produced by the Baker Institute for Public Policy, which provides meaningful policy analysis on the most critical challenges facing Texas, the United States, and the world. Baker Briefing is produced by Victoria Jupp, Shannon Moriarty, and Maria Morcos. AV production is led by Kevin Young. Visit bakerinstitute.org to learn more. Thank you, Elena, and thank you in the audience for listening.